You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 25th, 2021. This week, more about vaccine-induced myocarditis, lipid-lowering therapy, financial toxicity, and statins in older patients. First up, COVID. Cases in the U.S. remain super low. People here in Louisville have almost forgot about COVID. But I have some friends that moonlight in rural areas of Kentucky, and they say there are still some COVID hospitalizations in unvaccinated people. I had lunch with an infectious disease colleague this week, and he said neither he nor his partner have seen even one inpatient with COVID who was vaccinated. I read that even New York City is doing great with COVID cases, and I think it's just a testament to the efficacy of the vaccines. Now, one slight concern is that I noticed that in the EU and the UK, there seems to be a rise in cases. But I reached out to a colleague in France, and he sent me graphs on hospital and ICU admissions there, and there's no spike, at least yet. We'll need to keep an eye on that, especially with the Tour de France starting this weekend. Gosh, I love watching the Tour. Next topic is vaccine-related myocarditis. Again, it's back in the news. A group from the CDC presented data from the Vaccine Adverse Reporting System at FDA this week. And as I discussed last week, the signal of myocarditis from these messenger RNA vaccines is almost certainly strong enough to make causal claims, mainly because the observed cases are so much greater than expected. Now, not much of that is news, but what made news this week was a pretty robust online debate about the conclusions of the CDC panel, which basically were so strongly in favor of giving the vaccine to adolescents and young adults, even if they had had myocarditis or pericarditis before the first shot. Now, CDC Director Dr. Rochelle Walensky tweeted the following, quote, "If we vaccinate 1 million 12 to 17-year-olds, we could see 30 to 40 mild," and she made mild in capital letters, cases of myocarditis. But she also wrote, "In the same 1 million, through vaccination, we avoid 8,000 cases of COVID-19, 200 hospitalizations, 50 ICU stays, and 1 death. The benefits far outweigh the risks." Now, with all due respect, Dr. Walensky, there is a lot to disagree with here. First, while I agree that myocarditis severity comes on a spectrum, I read the myocarditis reports in these young people. Many of these were hardly mild cases. There were big troponin levels and ICU admissions. And these are healthy kids, and this is a preventive therapy of a very low-risk disease for kids. Calling myocarditis mild reminds me of the saying about minor surgery. Minor surgery is done on someone else. Similarly, mild myocarditis only seems to occur in other folks' kids. Second problem, citing COVID numbers like that assumes that the rates of hospitalization and morbidity with COVID will be the same as it was in 2020. Now, COVID morbidity and mortality going forward in the future seems highly uncertain. The third problem with Dr. Walensky's statement is people don't calculate risk like this. If they did, we wouldn't have problems with low anticoagulation uptake in AFib, for instance. People feel risk. Some fear the anticoagulation as much as the stroke, despite the data. So a lot of rational people will look at the risk of their kid getting seriously ill from the vaccine and want to take their chances with not having the vaccine. Other parents will feel more risk from the virus. Let's say the parents of a teenager have pre-existing conditions, or the kid has pre-existing conditions, or the grandparents do. They decide to have the vaccine, and that is perfect. That's how medical decisions should be made, with judgment and risk-harm balances and consideration of special circumstances. I strongly feel, though, that at this point, the emphasis now with only early safety data in kids, this ought to be up to the parents and patients to decide. Well, to be clear, I absolutely 100% love the vaccines for older adults and those with risk factors from COVID, or those who simply want the protection. But for young people, there seems time to wait for more data. Consider different regimens of vaccine, have shared decisions. Time will sort out things like whether lower doses are better, perhaps one shot, or delaying shots after a recent COVID infection. It boggles my mind that schools and colleges would be allowed to mandate a vaccine that could cause a serious heart condition in the current climate of so little circulating COVID-19. The good news is that FDA is finalizing language on a warning statement for healthcare providers, vaccine recipients, and parents or caregivers of teens. Next topic, lipid and lipid guidelines. The headline from the paper said, "Clinicians slow to implement lipid-lowering guidelines." This was from a JAMA Cardiology paper that used a registry called the Gould Registry. Gould stands for Getting to an Improved Understanding of Low-Density Lipoprotein Cholesterol and Dyslipidemia Management. It is a multi-center registry of patients who have documented cardiovascular disease. So we're talking here about secondary prevention. The study included about 5,000 patients, and to get in this registry, you had to be in one of three groups. One, you had to be taking a PCSK9 inhibitor. The other group was you had to have an LDL greater than 100. Or, the third group, you had to have an LDL between 70 and 99. Now, these were about 67-year-old, mostly white patients, BMI about 30. Now, first, recall that most guidelines recommend intensifying therapy if the LDL is above 70. Intensifying therapy could mean more of a statin, more potent statins, adding ezetimibe or PCSK9 inhibitor. The authors, led by Dr. Chris Cannon from Brigham, reported quite low levels of intensification of therapy. The top-line result that it was at 2 years, only 17% of these patients who had established heart disease had lipid-lowering intensification. 2/3 of these patients remained with an LDL cholesterol of greater than 70. Now, there were some interesting associations. Teaching hospitals seemed to do slightly better at intensifying therapy. Lipid protocols helped increase the amount of lipid therapy intensification. Cardiologists were more likely to intensify compared with internists. Now, my comments. The first thing to say is that this is a nice use of registries. Remember the saying, science tells us what we can do, trials tell us what we should do, and registries tell us what we're actually doing. So I love that the authors made no causal conclusions. Now, the second thing is that I always get slightly unnerved when reading comments like this, quote, "This is yet another disappointing reminder of how we are failing our patients." This was a quote from Dr. Anne Marie Navarre from Duke, and I have a ton of respect for Dr. Navarre and her work. But this comment bothers me, and here is why. Intensification of therapy is a preference-sensitive decision. Everyone agrees that taking more of a pill, taking another pill, or an injection, in the case of PCSK9 inhibitors, is a decision to be discussed with the patient. I find it problematic to promote shared decisions and then recoil that too few patients are taking a therapy. This happens often with anticoagulation guidelines. They give shared decision-making a Class 1 recommendation, and then in the same statement they say that anticoagulation is underused. You can't have it both ways, and it's the same with lipid-lowering therapy. While I agree that higher intensity statin or ezetimibe or PCSK9 inhibitors do indeed reduce the risk of future cardiac events, it is also true that from an individual patient's perspective, in absolute terms, the risk reduction is small. Consider the Improve It trial. This was ezetimibe Simvastatin versus Simvastatin, and the combination reduced the MACE endpoint by 2%. But the control arm was Simvastatin. Simvastatin is a very mild statin, and there were no differences in death or CV death. and these were in post-ACS patients, which is a clearly higher risk group. The differences were also small in the PCSK9 inhibitor trials. For instance, in the Odyssey outcome trial with alirocumab, the absolute difference for a MACE outcome was only 1.6%. And again, no significant differences were noted in death or CV death. And these also were patients who were post-ACS, higher risk. And recall also the point that my friend Dr. Luis Carrera makes. He likes to say that these absolute risk reductions are average and probabilistic. As a patient, you have no idea whether or not you will get any of the benefits from these extra therapies. Now, the third point I want to push back against Dr. Navarro's comment is that older patients here in their late 60s with documented vascular disease often have other medical problems. Many of these patients have issues with comorbid conditions and pill burden. Intensifying medical therapy may be no big deal for some of these patients, but for others, it's another pill or more cost. Now here I have to think about what Mayo Clinic cardiologist Victor Montori teaches, and that is about minimally disruptive care. In other words, doctors and patients have to prioritize. Effort and cost spent on another lipid-lowering drug distracts efforts from other problems, and some of these other problems may be more important to the patient than a preventive pill that has no effect on how they feel. Finally, I am totally 100% for doing everything we can to reduce adverse outcomes, but I think we should be at least a little skeptical about studies that document how hard real-world care is. Real-world care is harder than care that comes in the confines of a trial. Trials are a long way from real-world practice. Okay, the next topic relates well to the issue of preventive therapy. That is the financial toxicity of heart disease therapeutics. A paper from Houston Methodist DeBakey Heart and Vascular Center reports that financial toxicity, things like having trouble paying your bills, delaying care due to cost, non-adherence to meds, is greater in patients with heart disease compared with those with cancer. Now that finding surprised me. While it is very common, almost daily, for me to hear from patients about cost, I would have guessed that cancer care was worse. The authors from Houston Methodist DeBakey, first author Dr. Javier Valero Elizondo, used a national health survey of adults who self-identified as having atherosclerotic vascular disease. JACC Oncology published the paper. Now, the survey included 140,000 patients, and the paper considered about 6,000 patients who had heart disease, about 6,800 who had cancer, and about 1,000 who had both. In general, financial toxicity was about 25% more common in those with heart disease than cancer. Now, this paper has plenty of limitations, but the specifics aren't as important as the message. And it may seem nutty to some of my international listeners who come from countries with a national healthcare system, but here in the U.S., financial toxicity is a huge problem, and it's getting worse. And it's not just the very poor who are affected, it's the working poor. Now consider a private contractor who depends on his work. He barely makes enough to cover a catastrophic health plan that has high deductibles. Well, boom, he has an MI and a stent. The hospital stay will cover his huge deductible, and now he has to pay for his meds. And if he doesn't take his meds with a stent, he's in trouble. Now, I don't care what his LDL is on 80 of atorvastatin. There is no way this person is going to be paying for PCSK9 inhibitors. Then, what if he comes down with atrial fibrillation from the stress? Now we want him to take apixaban. Boom, another $400 every month. I am no policy wonk nor public health doc. I'm just a doctor trying to use the best therapies possible. But increasingly, it is simply impossible for some people to afford the best care. And again, as a doctor, you have to put on your Victor Montori hat and decide what is most important. I hope someday that enough social pressure gets put on policymakers to improve our system, but I am not optimistic that Americans will ever see the wisdom of a Canadian or UK system. Why? Because Americans are not used to people saying, no, we can't afford to pay for this or that dubious therapy. Last topic today is about statins and the elderly. Now, regular listeners of this podcast know that I am a fan of deprescribing to reduced pill burden. Older patients who are nearing end of life should eat food, not pills. Well, a study from Italian authors from the Lombardy region have published an observational study that finds discontinuing statins in older patients was associated with an increased risk of hospital admissions for heart failure or increased CV outcomes or even death. JAMA Network Open published a study. The lead author, Federico Rea, said this in a news article on the Heart.org Medscape Cardiology. Quote, statins are life-saving drugs, and according to the findings of our study, the discontinuation of this therapy has significant effects. Note the causal language. The discontinuation has significant effects. I will first tell you what they did, and then what they found, and then why this is dubious. First, the data came from utilization databases in Lombardy, and they used diagnostic and therapy codes. The first step was to identify patients who were receiving polypharmacy, more than 4 drugs. There were about 29,000 patients in total. The mean age of these patients was 76. The second step was to compare the outcomes among those who stopped the statin versus those who did not. About 23,000 patients maintained the drug, and about 5,800 patients stopped the drug, and those were the 2 comparison groups, so an uneven number of patients in each group. Of course, patients who did not and did stop the statin will differ in characteristics, so the authors did a propensity matching, where they tried to balance the stoppers and non-stoppers on the basis of characteristics that you can find in a database, things like cancer, brain disease, kidney disease, etc. They even used a comorbidity score to try and balance the groups. But notably, this was not a randomization. A doctor or patient or both decided to discontinue the statin. The main finding of the paper was that patients who stopped a statin had a higher rate of heart failure admissions, hazard ratio 1.24, higher rate of any CV outcome, hazard ratio 1.14, and a higher rate of death, hazard ratio 1.15, and each of those were statistically significant. My comments here are that this is a deeply problematic paper. But to be fair, the authors recognized the main problem, confounding, in the limitations part of their discussion, but I wish that they had put that in the abstract. Wish that more journals put limitations in the abstract. What I mean by confounding is that patients who decided, or doctors who decided, for whatever reason, to stop the statin likely differed from those who did not stop the statin. And it's those differences that are likely the causes of the worse outcomes. Authors of observational studies will use statistical models and things like propensity matching to try and simulate the balancing of groups, something that randomization usually accomplishes. But these statistical tools can only use the data that's on a spreadsheet. And any doctor knows, we all know, that many important patient characteristics do not show up on spreadsheets. And this is likely the case here. For instance, the strongest effect of statin discontinuation was an increase in heart failure admissions. But statins should have no effect on fluid overload syndromes. In fact, the GC heart failure and corona RCTs of statin use in patients with heart failure failed to show any benefit of these drugs. Why would the biggest effect be the heart failure admissions? Well, it's because stoppers, those who stopped the statins, were likely sicker than the non-stoppers, and that is why they had worse CV outcomes and death. Let me say that my feelings about statins have evolved over the past decade. I now believe that the RCT evidence with these drugs, and there are oodles of RCT level evidence with these drugs, clearly show that statins reduce CV outcomes over the long run by about 25%. Now, in absolute terms, it is a small probabilistic decrease, but it is real. If that is important to patients, fine, they can take them. But I also strongly believe that as multimorbidity increases, there are multiple other competing causes of poor outcomes. And the net benefit for overall health of preventing only one type of a bad outcome becomes less. When I deprescribe in the clinic, I often tell people who are in their 8th and 9th decade that the point of these preventive meds was that by taking them in their 50s and 60s, they actually lived to their 80s and 90s. Now, in older age, these drugs may be more of a burden than helpful. I think one of the dumbest things in all of medicine is when I see a thin, non-ambulatory, cachectic patient with any kind of disease still taking the statin. We should always be looking to deprescribe wisely, and I think this study does nothing to change that. So that's it for this week in cardiology. As always, thank you. I'm grateful that you listened. And remember, friends, please, if you like this podcast, take the time to give us a rating, write us a little review, tell your friends. This helps people find the podcast. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.